Hello, my name is John Fisher. This is the Society of Academic Emergency Medicine lecture series. Today I'm going to be discussing intravascular volume assessment by sonography of the inferior vena cava. In clinical medicine, determining a patient's intravascular volume status can really be an integral part of a patient's evaluation. This is particularly so in critically ill patients. Unfortunately, existing techniques for evaluating intravascular volume are suboptimal. This includes things like physical examination by evaluation of jugular venous pressure, and this also includes invasive measures whose results have been called into question, such as CVP measurements from a central venous catheter. Ultrasound has been used for over 30 years to evaluate IVC metrics as they relate to volume status. Some of the specialties that have used ultrasound include cardiology, emergency medicine, nephrology, trauma, and the list goes on. As a result of the many different specialties that have employed ultrasound in their clinical practice and in research, the literature is quite diverse, involving many different patient populations. Now, this certainly does make it challenging when one tries to distill the numbers to absolute levels of normal and not normal. When the dust settles, there are clear trends and principles which can be helpful in any clinical arena. Let's briefly go over IVC physiology. As you recall, the inferior vena cava is a very large capacitance vessel which has the ability to readily change its shape to accommodate the fluctuations in a patient's intravascular volume. There are the respirophasic changes that happen to the IVC. So specifically, as the patient inspires and the patient's intrathoracic pressure becomes increasingly negative, blood from the IVC is offloaded into the right atrium. This results in a collapse of the IVC during inspiration and an expansion of the IVC as the patient expires. This is visualized in the B-mode clip on the left-hand part of the screen in this longitudinal IVC view. Now, not only are there respirophasic changes, but there are also changes as they relate to the cardiac cycle. On the right-hand part of the screen, you see a M-mode clip of a transverse view of the IVC. And as you can see, the IVC actually looks pulsatile here. That's because it is. As you visualize this pulsation, note that the minimal diameter of the IVC occurs during early diastole, and the maximal diameter occurs during late diastole as the patient experiences the atrial kick. Indications for point-of-care IVC ultrasound. There are several. We're going to be focusing on this first indication, which is to evaluate intravascular volume. Okay, once again, this is particularly germane in the critically ill patient. And this is something that can be useful both at the initial evaluation of the patient when you're trying to get a sense of what therapeutic intervention to initiate, and it can also be helpful when you're trying to see if that therapy has worked or if you need to reverse course and perform the opposite intervention. IVC ultrasound is also extremely helpful when you're trying to evaluate for obstruction of venous return. We're not going to be discussing that at length in this lecture, but it is worth mentioning. So let's talk about scanning technique. With regards to patient position, the majority of the literature that describes the position of the patient describes the patient as being in the supine position. Now, as you can imagine, if you have a patient coming into the emergency department with acute decompensated heart failure, you're not going to be rushing to lie them flat because they may decompensate even further. Well, thankfully, there is some literature in which the patients were also evaluated in a semi-recumbent position, and there are even a couple abstracts in which the same patients were evaluated in both semi-recumbent and supine, and there was no significant difference between the metrics. With regards to the patient's respiration, in some studies they did have the patients perform a sniff technique, so just basically having the patient sniff prior to determining the minimal diameter. This can be challenging to standardize, so I would recommend that you just measure the maximal and minimal diameter during passive respiration. With regards to transducer selection, you want to make sure that you pick a transducer that has a sufficiently low frequency to enable you to visualize the IVC. Two options include the phased array transducer or the curvilinear transducer. both of which have middle to low frequencies. Each of them has particular advantages over the other. So let's start with the phased array. So this transducer here is nice for several reasons. First of all, when we perform an IVC study, we commonly couple it with a point-of-care echo. The phased array transducer is the transducer of choice for performing a point-of-care echo. So it will be one less step when you want to go from your echo to your IVC study. In addition, if you have to perform an IVC study by the right intercostal approach, the small footprint of this transducer will enable you to readily sneak between the ribs and visualize the IVC. On the other hand, you have the curvilinear transducer to the right. So this transducer, as you can see, has a very broad footprint. This footprint is attractive because it can provide a very wide sector of imaging, and you can see a lot of the adjacent sonoanatomy. With regards to transducer placement, there's the subxiphoid approach, which is indicated as SX in this image, and there's also the right intercostal approach indicated as IC. The subxiphoid approach can be appealing because, as we talked about in the previous slide, a lot of times when you do IVC studies, we couple it with an echo, and we do often use a subxiphoid approach when performing a point-of-care echo. So it's an area that we're very familiar with. It would also require one less step when you are switching your study from a point-of-care echo to a point-of-care IVC study. You just basically have to change the angle of your transducer. One of the challenges sometimes clinicians face when performing a study with a subxiphoid approach is that some patients don't tolerate any transducer pressure in this area, particularly if they're presenting with abdominal pain. And lastly, there's a theoretical pitfall of the clinician providing excessive transducer pressure, which can actually produce a compression of the IVC and can make them think the patient has less intravascular volume than they actually do. So the other approach is the right intercostal approach. This approach does not allow for compression of the IVC because there's protection from the overlying rib cage. In addition, patients who may not tolerate scanning in the subxiphoid region because of abdominal tenderness or perhaps because of wounds or dressings in this area, the right intercostal approach provides a nice alternative. The main challenge with the right intercostal approach is trying to navigate between the ribs to visualize the IVC. This can be made easier if you use the smaller footprinted phased array probe. Also note that both the subxiphoid and intercostal technique can be used to visualize the IVC in either the long or the transverse axis. Let's talk about the imaging axis of the IVC. Do we want to look at it in the longitudinal or the transverse plane? So really each one of these has pros and cons, so let's briefly talk about each one. So on the left hand side you see a still image of a longitudinal view of the IVC. This is very nice because we can see a lot of the relevant sonoanatomy. We can see the IVC, which is labeled, and we can see it draining right into the right atrium of the patient. So this is positive identification that this vessel that we're visualizing is indeed the IVC. We can see the diaphragm, which can be important to see because sometimes patients have very strong diaphragmatic attachments, which can produce a constriction of the IVC. And lastly, it's important that when you measure the IVC, you get as perpendicular as possible a measuring plane to the main IVC vessel axis. And the reason that this is important is because if you approach the IVC with an oblique measuring axis, then you're going to get larger diameters and you're going to make the appearance that the patient has more intravascular volume than they actually do. Using the longitudinal approach allows you to readily visualize the measuring axis as it relates to the vessel axis. Now we're going to go over the main pitfall of the longitudinal approach. So take a look at the right hand side of the screen now. This is a slice of the IVC, a transverse slice of it. And this is just a simulation of what happens when we perform a longitudinal approach. So we can see in this case the transducer is placed almost perfectly in the center of this vessel, and it's going to yield an accurate assessment of the patient's volume. In this case, it's going to lead the clinician to provide some furosemide because maybe they think the patient has excessive intravascular volume. On the other hand, if by mistake the clinician slides a little bit off plane, they're going to produce an entirely different picture which in this case is going to lead to the inappropriate intervention of volume expansion. So it's critical that if you do measure in the longitudinal axis, that you be very careful that the transducer is kept in the center of the vessel. With regard to the transverse axis, once again we're seeing the relevant sonoanatomy. As you see in front of you, we can see the vertebral body at the bottom of the image, and towards the patient's left we see the large vessel, which is the aorta, and towards the patient's right we see the IVC. And in this case, when we measure the IVC, we can visualize the measuring axis, and in this case we'll be able to make sure that that measuring axis runs exactly through the center of the vessel. We're not going to experience the pitfall of sliding off plane. However, we lose the ability to ensure that the measuring axis is perpendicular to the main vessel axis. This is one of the main challenges of visualizing the IVC in the transverse plane. As you can see, both the longitudinal and the transverse axis offer unique advantages over one another, so I would actually recommend visualizing the IVC in both planes, which after a little practice takes no more than a few extra seconds. This is an extremely important slide. It's absolutely critical that you be able to correctly identify the IVC. I find that it's easiest to start in a transverse axis. So we're going to start by reviewing the B-mode clip to the right-hand part of the screen, and we're going to go through the relevant sonoanatomy. At the deepest aspect of the B-mode clip, you can see there's a echogenic, smoothly surfaced structure with shadowing deep to it. This is the vertebral body. Okay, this is the anchor of this view, and I would encourage you to first identify this prior to attempting identification of the IVC. So now we've identified the vertebral body. You can see that there are two large vessels superficial to it, one on the patient's left, which is the aorta, the other one on the patient's right, which is the IVC. And you can see there are actually several small vessels coursing toward the IVC. These are hepatic veins. After you've identified the IVC in the transverse axis, I would recommend rotating your transducer 90 degrees to visualize the longitudinal plane. This is a bedside example of that, starting off in the transverse plane. Let's take a look. Transverse view. As rotating, we get to the longitudinal view. He then rocks the probe a little bit to get a measuring axis, and he slides the transducer down a little bit to visualize more of the key area. Great. Where to measure? Thankfully, Wallace and colleagues have actually studied where would be the best place to measure. In the literature, the three main areas which are commonly measured include the IVC at the RA-IVC junction, as depicted in the top still on the right, within 2 centimeters distal to the IVC hepatic vein junction. Here we can see the hepatic vein draining into the IVC, so we're going just distal to that. These are centimeter marks on the side, so we can see that we're around 1 centimeter distal to the IVC hepatic vein junction. And the last place is measuring the IVC at the left renal vein junction. This is visualized in the still image on the bottom right of the screen. We can see the vertebral body, we have the aorta. In this case, we're visualizing the SMA. We can see the left renal vein coursing between the SMA and the aorta, and this is going to be your IVC. And what they did in the study was measure the IVC collapse index at all three areas in healthy volunteers. What they found was that the measurements at the RA-IVC junction were relatively small compared to the other two areas. They hypothesized this was due to a relative decrease in compliance from strong diaphragmatic attachments. The measurements at the other two areas correlated well with one another. However, I can tell you anecdotally, it's easier to consistently visualize the IVC within 2 centimeters distal to the hepatic vein junction than it is to visualize it at the IVC left renal vein junction. So I would recommend visualizing the IVC within 2 centimeters distal to the IVC hepatic vein junction. When we're evaluating the IVC, what are we looking at? So first we're actually doing just that. We're looking at it. The first evaluation is a qualitative one. We're looking at the shape of the IVC. There are some trends in the shape as they relate to volume status. On the left-hand part of the screen here, You can see this is a transverse view of an IVC, which looks like a circle. This is typically seen when you have a patient with excessive intravascular volume. The next appearance is more of a football-shaped IVC, and this tends to be in patients that have normal intravascular volume. And the last extreme is the pancake IVC, which you see on this M-mode clip to the right. And this is consistent with intravascular volume depletion. So here's a real-life example. This is a patient with a lactate of 4. They've already received 2 liters of fluid, and you do this IVC study. Here you can see a transverse view of the IVC. So just by doing your qualitative assessment, what would you think? More fluid, or is the patient already adequately resuscitated? I agree. This looks rather pancake-like, and I think this patient does indeed need more fluid and has a volume deficit that's greater than 2 liters. So next, let's get to quantitative metrics. In this slide, we're actually going to talk about how to obtain the metrics, specifically minimal and maximal diameter. If you're going to be using B-mode, this can be done by directly visualizing the minimal and maximal diameter of the IVC, hitting freeze when you achieve those moments, and measuring the diameter using the electronic calipers. This may be more easily done by visualizing a full respiratory cycle and then hitting freeze and using the cine loop function to backtrack and measure the diameters at that point. Another option, which allows visualization of both the maximal and minimal diameter on one still image, is scanning the IVC using M mode. M stands for motion. And basically what this does is it takes this line, which is coursing through the liver and transecting the IVC in a transverse plane, and it displays that line over time. And what this allows the clinician to visualize is the respiratophasic change of the IVC over time. So in this case, we're seeing the calipers marked as A being the maximal IVC diameter. The patient inspires, IVC collapses. We have the B calipers here, which are the minimal diameter. I just want to caution that if you're going to use this technique, you want to make sure that the sweep speed is set low enough so that you can visualize at least one full respiratory cycle, so you can accurately measure the min and max IVC diameter. An additional quantitative metric is the IVC collapse index, also known as the IVC cable index. And this can be thought of as a type of IVC ejection fraction. And essentially, you're going to take the maximal IVC diameter, you're going to subtract the minimal IVC diameter from that, you're going to take that number and divide it by the IVC maximal diameter. Typically, the collapse index is reported as a percentage. When you approach 100%, that means that the IVC has near totally collapsed, and the patient is probably intravascularly depleted. When you have a very low collapse index, such as 5%, then that is typically seen in patients who have excessive intravascular volume. This is an example of an IVC collapse index calculation. This is another M-mode still image. You can see here that the max and min IVC diameter are quite large, and the collapse index in this case is going to come out to be 9%. So, interpreting the numbers, why do I have an asterisk next to the title of the slide? The reason is, as we discussed initially, the numbers can be quite challenging to interpret because of the very broad and diverse range of literature and the many different patient groups that make up the data. So let's just go through some specifics. With regards to the IVC min diameter, the minimal diameter that's reported as normal ranges from approximately 0 to 14 millimeters. The maximal diameter that's reported as normal ranges from 15 to 20 millimeters. Generally speaking, if you have a max diameter less than 10 millimeters, that is consistent with the patient being hypovolemic. With regards to the cable index or the collapse index, the numbers are more helpful at the extremes. As you approach 0%, it is consistent with the patient being hypervolemic. In the middle ranges from about 25 to 75%, it's typically consistent with a patient being euvolemic, and as you approach 100%, it is consistent with hypovolemia. Now, I do want to caution you that when you get these metrics, you don't want to view them in isolation. An example that demonstrates why that can be problematic is if you had an IVC max diameter of 3 millimeters and an IVC min diameter of 2 millimeters, that would produce a cable index of approximately 33%, which would fall in the generally euvolemic range. However, with this max diameter of 3 millimeters, this patient is very hypovolemic. So you want to use these numbers in conjunction with one another. Let's go over some specific values from populations of interest. Dr. Negdev and colleagues in 2010 did a study where they evaluated IVC metrics in patients who had central venous catheters evaluating CVP. They found the correlations that are listed above. They also found that an IVC collapse index of greater than 50% was strongly associated with a CVP of less than 8 millimeters mercury. Dr. Blihar and colleagues in 2009 did a study on emergency department patients who presented with acute dyspnea. They found that if the patient had an IVC collapse index of less than 15%, it had a sensitivity of 93% and a specificity of 84% for the diagnosis of congestive heart failure. Dr. Lyon and colleagues in 2005 did a study that was to simulate hemorrhage. These were volunteers giving blood, and they found that when they evaluated the max and min diameter pre and post blood donation of 450 cc's, the measurements reliably decreased 5 millimeters. So next, I want to emphasize that it's important to look at the whole picture with regards to the changes of the IVC. Specifically, the patient's cardiac function is going to have a very significant impact on the IVC metrics. So you do want to include a point-of-care echo when you evaluate the patient's IVC metrics. So taken in isolation, this M-mode still image would be suggestive of excessive intravascular volume. There's the IVC in transverse view. There's max, there's the min. You can see that it's really plethoric and there's minimal, if any, collapse during inspiration. This is the point of care echo that corresponds to this patient. This is a peristernal long axis view. You can see that the right ventricle is dilated and its diameter is significantly larger than the left ventricle. This is consistent with right ventricular failure, which in this case is likely the cause of this patient's plethoric IVC, rather than being from excessive intravascular volume. Another example of looking at the big picture is performing a point-of-care lung ultrasound when you suspect decompensated heart failure as a way to increase your diagnostic certainty. To do this, you're going to be putting the transducer on the patient's chest wall, and you're going to be looking for B-lines. B-lines are a reverberation artifact which stem from the pleural line. You can see them in this clip. Basically, they will extend to the depth of your screen. They will obliterate everything in their path, and they will get broader as they go deeper. Just a few miscellaneous points I want to mention. Please recall that positive pressure ventilation produces distensibility of the IVC. This will cause an overestimation of the patient's volume status. And also, it's good to note that if the patient is on positive pressure ventilation and their IVC metrics are consistent with hypovolemia, then that patient is profoundly hypovolemic. Patients with hepatic fibrosis or cirrhosis tend to have stiff IVCs that do not have the usual amount of collapse during inspiration. Athletes tend to have large IVCs. And the thought is that this is a compensatory mechanism to accommodate their frequently high demand for cardiac output. Some pearls. You want to incorporate a focused echo into your IVC evaluation, as we just discussed a couple slides back. Imaging the IVC in two planes has the potential to offer significantly more data than visualizing in one plane, with really minimal extra effort and probably no more than a few seconds of time. Serial exams to monitor response to treatment can be extremely helpful. Pitfalls. Failure to properly identify the IVC. This can be avoided by reviewing the relevant sonoanatomy prior to obtaining your IVC metrics. Another pitfall is misinterpreting IVC pulsation as respiratory variation. And you can avoid this pitfall by making sure that the cyclical changes of your IVC diameter correlate with the patient's respiratory rate, not the pulse. Lastly, blind faith is a pitfall. When you have IVC metrics that do not fit the clinical presentation, you need to reevaluate your IVC study and make sure, for example, that you're indeed looking at the IVC, and you also need to be reevaluating your patient to try to reconcile the difference. If the difference cannot be reconciled, then you have to ignore your IVC study and treat the patient as if you didn't have the ultrasound result. Blind faith in any test, including ultrasound, can be quite dangerous and has the potential to do more harm than good. So in summary, sonographic IVC evaluation provides a non-invasive means to determine intravascular volume status, and it can be done several times in the same patient, both at the index evaluation as well as following therapeutic interventions. Correct IVC identification and point-of-care echo are prerequisites for an accurate study. With regard to the metrics, they are more helpful at the extremes. Generally speaking, a low IVC collapse index of about 0 to 25% would be considered hypervolemic. When you approach the higher numbers, 75 to 100%, the patient may be hypovolemic. According to Dr. Negdev's study, an IVC collapse index of greater than 50% was strongly associated with a CVP of less than 8 millimeters mercury. And most would agree that an IVC max of less than 10 millimeters is consistent with hypovolemia. Let's just do a quick rapid fire review to drive home some important points. So what do you see here? This is a very short clip, I know. So this is actually an aorta. Okay, this is not an IVC. I wanted to start off with this clip just to once again emphasize that you cannot call it an IVC until you visualize the relevant sonoanatomy. You can see in a subsequent clip here that we are just adjacent to the patient's IVC, which has come into view now, and this just gives an example of how easy it is to mistake one vessel for the other. Here we can see the IVC, we see the hepatic vein coursing towards the IVC, and we can see the IVC going into the patient's right atrium. So now we've positively identified the second vessel as the IVC. Okay, what do you see here? Let's just go over some of the anatomy. Vertebral body, IVC, aorta, hepatic veins. This is a longitudinal view of the IVC. You can imagine maybe a hepatic vein going into it, but it's very, very small. And the IVC is also very small. This is a small IVC that has total inspiratory collapse. This is consistent with a picture of volume depletion. Okay, try to point out the anatomy. Good. There's the IVC. You see the hepatic vein draining into it. And you can see the IVC draining into the right atrium. Okay, here you can see the sonologist has transitioned from the longitudinal view to the transverse view. This is done readily by slowly rotating your wrist 90 degrees to view the orthogonal plane. Okay, what do you think about the patient's volume status here? Let's take a look, let me know what you think. Transverse view of the IVC. You can see the hepatic veins coursing toward it. Okay, so at the very end, did you guys catch that? That was a patient who had a large circumferential pericardial effusion with a evidence of tamponade physiology. So this is exactly why it's critical that we include a point-of-care echo with each IVC study that we do, because the pump is going to play a major role into the IVC metrics. And here are the relevant references. If you have any questions, please feel free to email me. My email was on the cover slide in the beginning. And lastly, I just want to thank you all for your attention, and I'd like to just acknowledge a few people. I want to thank Dr. Megan Herbst and SAEM for the opportunity to do this lecture, and I also wanted to thank my former fellowship directors, Dr. Anthony Dean and Dr. Nova Ponabianco. Have a great day. Thank you.